I think that was a lot of the backlash is about the guidelines. People said, well, you can't just give kids and adolescents and teenagers medicine and they're just going to not do the work. And it's a quick fix and you're not really fixing the problem. And that's exactly right. Like you can't just give someone a prescription and say, see you later. And that would not be recommended for any medication, right? In pediatrics. So this is always in light of, look, here's a medication that will help your metabolism. It'll help regulate your hunger and your fullness, your satiety. It'll work on the biology while you work on the other stuff with us as a team, and I think it's a give and take. We're going to help you medically, but here's some, let's talk about what you and your family feel like they can change in your environment.
Hi, and welcome back to the Eat Your Greens with Dr. Black podcast. I am so glad you're here. I have something really special planned for you today. You are not going to want to miss this episode if you or someone you love is affected by obesity. And that covers a lot of people. It's a very common issue. And so we're going to talk about pediatric obesity in particular on this episode. If you're new to the podcast, thanks for joining me. I hope that you learn a lot and that you are motivated to come back every week to hear a new episode. If you're a returning listener, thank you again for your support. It really means a lot. So today I am joined by a pediatric obesity medicine specialist, and we're going to have a very interesting conversation, a detailed conversation about what pediatric obesity is, why it's such a concerning issue, and some of the things that we can do about it. I'm joined today by Dr. Katie Queen. She's board certified in both pediatric medicine and obesity medicine, and she's the medical director of the Pediatric Multidisciplinary Weight Management Center at Our Lady of the Lake Children's Hospital in Baton Rouge, Louisiana. She is a research scientist through the National Institutes of Health, and she's the primary investigator on a grant-funded study looking at how weight management counseling affects behavior change and pediatric obesity in adolescents. She's the co-leader of the Louisiana State American Academy of Pediatrics Chapter Committee on Obesity and Nutrition, and she's the founding board member of the Louisiana Obesity Society. So I am beyond honored to be joined by Dr. Queen today. She's really an expert in the field, and I think you're going to learn a lot about pediatric obesity. So, Dr. Queen, thank you so much for joining me.
You are so welcome, Angela. I'm pleased to be here.
So I see that you work in Baton Rouge, but you actually are based over in Covington.
Yes.
And I know Covington because I have some cousins. I have a bunch of cousins in the Slidell, Covington area, some family members over there. So, yeah.
So if you've ever been to New Orleans, it's about 45 minutes north of New Orleans. I grew up in a town outside of New Orleans called Metairie. But I'm a girl from Louisiana, went to LSU medical school residency, and I did actually go to University of Texas for college. So I've been in Texas for a little bit of my life, and I lived in Houston right after residency. So I'm familiar with Texas, and you're up by San Antonio, right?
Yes, we are halfway between San Antonio and Austin.
Yes. So in college, we used to go to the San Marcos River, and we would ride on those tubes. So I have great memories of San Marcos and the San Marcos Mall.
Right. Our outlet malls and our river, those are the two things. And then we have Texas State University here as well. So, yeah, it's a great place. We love our river here in San Marcos. And for those of my listeners who don't know, I was born in New Orleans. So we have some connections there.
I didn't know that. Awesome.
Yeah. My mom's
what hospital?
Family. Oh, it's not even there anymore. It was a military hospital. Does not exist.
Okay.
No.
Maybe we could be born in the same hospital.
Oh, no. My dad was Air Force. And so there was this military hospital there back. Of course, this is the 60s because I've been around the block a few times now, but didn't ever really live in New Orleans because we were a military family when I was very young, but spent lots of time there with family. And then they all eventually moved out of the city into Slidell and then kind of spread out into that surrounding area. So out there in the woods.
Yep,
So it's
yep. I'm out here surrounded
beautiful.
by woods. That's right.
But you make the commute over to Baton Rouge to work in the obesity medicine clinic, the pediatric and adolescent obesity clinic. Tell me a little bit about your practice there and what y'all do.
Sure. So, about an hour west of where I live is Our Lady of the Lake Children's Hospital. So there's two, let's some debate, three children's hospitals in Louisiana, and the one that I work at is in Baton Rouge, which is the capital. And in that clinic, we started it about 3 years ago, and we have currently, actually, as of last week, we went from a 1 day a week clinic to a 5 day a week clinic. So we're a multidisciplinary Pediatric Obesity Weight Management Center. We actually wanted to call it a center because we envision it doing more than just having a clinic. But currently, we have 3 dietitians that actually rotate through. We have a social worker who addresses social needs, but also things as simple as, oh, you want to get involved on a baseball team? Let me help you find something in your neighborhood. So we have a nice team. We have a full-time nurse coordinator and a medical assistant, and then we have another pediatrician like myself who's there and rotates through. And then we also have residents who rotate through, pediatric residents. And then we just hired a full-time physician assistant. So super excited to say we're growing, and we are the only truly multidisciplinary clinic in the state of Louisiana for obesity.
It's great that it's there. They're really hard to find.
Yes, because the investment and the time, just to give you an example, it took us an hour just in the planning phase to get our health system to buy in, to get the financials set up, to get the electronic medical record set up. I counted it took us over a year actually of meetings and preparing. And so it's not something that I take lightly. And we've only been 1 day a week with a wait list of 750 patients or more. For 3 years. And we had to be okay with that because that's all we could do. And now, thankfully, we have the support of our health administrators to hire a full-time PA as of last week.
And I think that really illustrates the urgency of the need for this kind of care, that this has been a largely undertreated, underrecognized problem. And we're having a greater understanding of how much of an effect on someone's health this issue can have of obesity. But I do want to take a little bit of a step back because there are definitely people who, and I have a lot of respect. I've said this before on other episodes. I have a lot of respect for the body positivity movement, the health at any size movement, in that we really don't want to stigmatize people who are experiencing obesity. On the other hand, I think treating it as not a health issue, it's really a chronic disease. And when we ignore that element, we're really not giving them the medical care that they need to not only be able to be active and live their life, especially kids, do what they need to do, but also, preventing future issues. And when we say future, it's not even that far down the road. So I think striking a balance between looking at obesity as not an issue at all versus, the stigma. I really appreciate that you are doing that work and how much it's needed. Why do we say that obesity is a chronic disease? Like, why is it an issue that deserves our attention as physicians?
Right. And that's a great question. So, the word obesity technically is defined by a patient's body mass index, which is basically an estimate of body fat. And, there's a lot of debate over whether we should be using BMI or something else, but BMI is what we have right now. And what we know is that when the human body accumulates more fat than it's designed to have, and when I say fat, it's called adipose cells, or the actual fat cell. It's good to have fat, right? We all need fat. If we're too skinny, then we won't be warm in the winter, that kind of thing. But when the body gets to have too much fat, basically what happens is the fat cells, or the adipose cells, are actually endocrine organs. In fact, they're one of the largest, if not, I think the largest endocrine organ in our body. And then they secrete all these different hormones that then disrupt our natural hormone system. So that's one problem. And then the second problem, why it's considered a disease, is because the fat cells then start to take over, almost like a cancer cell would, take over the healthy functioning cells. So in the liver, for example, the fat cells will start to push out the healthy cells, which is basically what fatty liver starts as. And then later there's some inflammatory changes and scarring, things like that. So the point is, it's two things. There's a hormonal change that makes it a disease. And then there's also a change in the structure of the body and how things are functioning, fat around the heart, fat around the liver, etc.
That was a great explanation. I don't think I've ever heard it put just like that. I understand that it's a metabolically active, a hormonally active tissue, and can definitely be pro-inflammatory, but I haven't appreciated that structural component in the past where the cells are actually taking over an organ and then disrupting the function in a very direct and physical manner.
Yeah, so the term for that is fat mass effect. And when I studied for the obesity medicine boards in 2020, it was kind of my COVID crisis. I decided to do something while I had extra time. I learned so much more than I ever learned in medical school. And so I think that's why most doctors don't even always recognize it as a disease. Not only that, there's disruption of the insulin metabolism, and then the way that the brain talks to the gut. So there's a lot of connections that are super complicated going on. And we say it's a disease because once the signaling is not talking the fullness, the satiety, once the signaling is not working correctly, it becomes a vicious cycle. And we say relapsing disease because if you have a patient who loses weight, it's also going to be normal for the body to create hormones to counteract your weight loss. So it's a relapsing disease because the body's natural mechanisms sort of fight weight loss. Our bodies, just based on genetics, are built to hold on to weight way more than we are to lose weight. And the compensatory hormones that lead to weight regain are a big part of why we call it a relapsing chronic disease. It's way more complicated than I can explain on this podcast, but it's so much so that they had to create a board exam for it.
Right. And so when people say, why don't they just eat better and exercise more? It's not as straightforward as calories in, calories out, although that is a part of it for sure.
Yeah, and I like a good analogy that I like to use with patients is, if calories in, calories out in a perfect world, that might be true. If we eat less and we burn more calories, it makes sense we would lose weight. The problem is that not everybody's car is designed the same. So imagine like I'm an old breaking down, car from the 1970s. My car is not going to burn the gas as efficiently as the new Tesla, right? So let's say you have a Tesla and I have an old car. Yeah, we can put the same amount of fuel in, which is the food in, but our cars are not going to burn it the same. So everybody's individual genetics, along with our social sort of socioeconomic family environment, and then on top of that, the endocrine hormonal changes, all of that is what ends up leading to the disease of obesity.
I love that analogy. Now, because it's such a growing issue, just last year in 2023, the American Academy of Pediatrics released their first ever clinical practice guideline on the treatment of pediatric obesity. And for people who don't know, a clinical practice guideline is where the experts look at all the evidence related to a disorder, and then they come to an agreement about what the best approach to treatment is. And prior to 2023, there was some documents, some advice given, but there was not a formal clinical practice guideline ever published before. And we have that now, but it garnered a fair amount of attention and generated some controversy because of the recommendations. Tell me a little bit about without going into too much detail, a little bit about what the clinical practice guideline says that we as general pediatricians, so someone like me who's not board certified in obesity medicine, what should I be doing at my level when I have a patient who comes in and meets the criteria for pediatric obesity?
So that's a great question. And the American Academy of Pediatrics has done a really good job of creating a lot of implementation resources. We can put that in the show notes. There's good websites with lots of algorithms that you can laminate in your office. But I think the main shift from the past to the present is no more watch and see, no more watchful waiting, no more stepwise. Well, let's, counsel them on their eating habits and their exercise for a while, 3 to 6 months. And then maybe we'll send them to a specialist who maybe will give medicine and then who maybe will send them to a surgeon. So less stepwise, more aggressive in that the guidelines, and these are evidence-based guidelines, recommend that we should be offering all the options that they're eligible for at the time of diagnosis. So let me give you an example. The old school way would have been patient comes in, body mass index is in the obesity range. Pediatrician sees them for like the 8-year-old visit, says, oh, I noticed the weight's going up a little bit high, but it's okay. Just have a little less soda and work out a little bit more. And we'll just check it. We'll check it next year and I'm sure he'll get more active. It'll be all right. And maybe a severe case might get referred. New guidelines, this is what it should look like. That 8-year-old at that time of diagnosis for obesity really should be offered nutrition and lifestyle counseling. Now that can be done with a pediatrician through the American Academy of Pediatrics. They have next steps booklets you can get, and you can teach yourself how to coach on nutrition and lifestyle. Or you can find a community program like a YMCA, or you can find an intensive program in your area. For example, our clinic offers a somewhat intensive program. So that's number 2. And number 3 is that pediatrician really should be offering medication if they're eligible and if the risk-benefit ratio is suggesting that the family wants to consider medication. And that's for any child or adolescent 12 and up with a BMI of 30 or higher, or a BMI of the 95th percentile or higher. And that doesn't have to be done by a specialist. And I say that because I think that we get scared as pediatricians who weren't trained in obesity medications. We get scared to even think about, oh, how could I prescribe that? But if you think about it for ADHD, we prescribe how many different ADHD medications are there out there? There's probably 25 or something like that, different medications with all different tiered dosing. And obesity medication is actually much simpler. We only have 2 injectables. We have 1 by mouth, approved age 12 and up. And then just to finish the conversation, any child with a BMI 40 or higher, or above the 140th percentile or higher, you really should be offering them a referral to a bariatric surgeon. It doesn't mean they have to have surgery, but as a primary care doctor, the patients need to know that there's options, and they need to not feel like, oh, they just have to go eat healthier and exercise to fix their problem.
And if my listeners stay tuned, if you're subscribed and getting my email alerts, my next episode is talking about bariatric surgery. So this is a 2-part series, one focused on non-surgical treatment. And then I do have a conversation coming with a pediatric surgeon to talk more about that, because people are curious and also shocked. I've had lots of people say, what, surgery for kids? So definitely come back for the next episode talking to the surgeon. Now, you mentioned medication, and you are spot on about pediatricians feeling very uncomfortable prescribing those medications because we haven't been trained at all. Maybe metformin was just starting those sorts of medications for adults with diabetes, but not for kids. And I know there are different types. We are going to talk about the new GLP-1 agonists, but start by telling me a little bit about what other medications are out there for treating pediatric obesity.
So other than GLP-1s?
Correct.
Okay. So currently on the market, and there's a lot more that are in the studies and about to be out. There a lot of them go through phase 1, then phase 2, then phase 3 studies. And we've got a lot of drugs in phase 3 studies about to be on the pipeline. But currently we've got the GLP-1s. There's 2 of them approved, semaglutide and liraglutide, which we can talk about more in a second. And then the third one is the oral option called Qsymia with a Q. And basically it has 2 medications in it, and it's in slow release capsule, and it's a combination of topiramate with phentermine. Now, phentermine, it is a controlled substance, just like Adderall or some of your stimulants or all of your stimulants. However, it's 2 classes below Adderall. So Adderall, Vyvanse, things you hear about are are really a class 2 medication, and phentermine is a class 4 stimulant. So that being said, there's no abuse potential, there's no withdrawal potential, there's no dependency. There may be a small amount of tolerance that patients tend to get on the phentermine, but other than that, very safe drug. In fact, it's the longest obesity drug that we've had on the market since about the 1970s, and also the cheapest drug. So I just want to make sure everybody understands phentermine is safe, and it's not fen-phen, which in the I don't know what year it was, they took that off the market. That was a completely different molecule. So
I think
it's a
it was
phentermine
even
with
in the
topiramate.
80s. I think
The
it was
80s, yeah.
not as far back as the 70s that it was removed. And I'm glad you brought that up. And, people have heard me talk about my special needs daughter before. So fen-phen was fenfluramine and phentermine together. And it was effective in treating people with obesity, but it had some effects on the heart that were very serious. It damaged one of the heart valves and it led to something called pulmonary hypertension. So, like increased pressure in the lungs, and that can be very damaging. And so it was pulled from the market for that reason. And the reason I mentioned my special needs daughter, she has a serious genetic epilepsy. And specifically for her seizure disorder, fenfluramine was studied in Europe and found to be really effective. And this is an epilepsy syndrome that does not respond to pretty much anything else. And so a study was approved here in the United States. She was a part of that study. It did end up being approved. So she is on fenfluramine, and we went from 50 to 70 seizures a month to we had a whole year seizure free. It's been her miracle drug. It's incredible. But she has to get echocardiograms every 6 months to look at her heart valves and check for pulmonary hypertension. Is that a requirement with the obesity medication?
It is not, and I think that's just because it's been around long enough that they haven't had any heart concerns. Now, there's maybe a slightly increased blood pressure or heart rate, but it's not anything significant. They're saying, maybe up to 5 beats per minute of heart rate difference. But just as you would with any kid, if you're going to prescribe an ADHD stimulant, you would consider an EKG if there's a strong family history or if they have arrhythmia, exercise intolerance. If they have symptoms, you're going to get an EKG, but there's no universal recommendation that you have to get an EKG before prescribing this Qsymia or phentermine. Phentermine alone, by the way, is approved 17 years and up. But when we're talking about adolescents, younger adolescents, Qsymia is the only thing that's approved that's oral, 12 and up.
And it's in combination with topiramate, which is also a seizure medication, but it can cause appetite suppression. And so it's been used for that. Do you ever use it by itself, or is it not?
I do. I do. I don't find it as effective for sure as Qsymia, but because topiramate is approved down to age 2 for seizures, we know that it's had a long time of showing to be pretty safe and effective for children. So I do, like if I have a 3-year-old with severe obesity and what we call hyperphagia, which is a child that has just insatiable hunger, just is always wanting food, then we'll give topiramate to sort of curb the hunger. And it just works on certain areas of the brain that reduce appetite. So I do prescribe it off-label down to age 2 in most severe cases. I would not expect a pediatrician to do that, though. I feel comfortable just through all the extra training I've done. But a general pediatrician or family practice doctor, they should really feel comfortable. If they're comfortable with ADHD meds, I would like to challenge them to try to consider Qsymia because it's actually a weaker stimulant and it has that topiramate to help. It's a synergistic sort of effect of the phentermine and topiramate.
And what about metformin? I've also seen that used as, I know it's indicated for diabetes, but is it prescribed as a weight loss medication or only in the setting of diabetes or prediabetes?
Yes. So metformin is not classified as an obesity or weight loss medication. We like to actually, if you look at the literature, they like to call it anti-obesity medication, but I like to just call them obesity medications. But in order for the FDA to classify it as such, it has to have 5% weight loss or 5% BMI reduction. And metformin is an average of more like 2 to 3%. So while metformin can lead to a little bit of weight loss, it's technically not used for weight loss. And I usually only prescribe it for patients with prediabetes, diabetes, And honestly, with the GLP-1s, I'm prescribing it a little less than I used to, just because the GLP-1s are way more effective than metformin.
And then one other non-GLP-1 medication that I've come across that's being used, I suspect off-label. And for people who don't know what that means that the FDA has not specifically approved the medication for this use, but sometimes, especially in pediatrics where we don't always have studies, we use it outside of the official FDA indication. So it's another seizure med, lamictal or lamotrigine. Have you seen that used at all?
I have not, no. And that wasn't even in the guidelines as one that's been studied. There are some other ones like orlistat that still have an FDA indication, but lots of GI upset, and it's technically over the counter. But I don't know any obesity specialists who use it. But no, I have not heard of lamictal being used for weight loss. In fact, some of the seizure meds can cause weight gain. But I'd have to look that one up. You stumped me on that one.
Let's move on to GLP-1 agonists because I know that my listeners, that's the one they really want to hear about. They're hot topic. Lots of people are taking them now. Tell me more about, first of all, should kids be prescribed GLP-1 agonists? I have a feeling I know the answer already. Who, which ones, what age? Tell me more about that.
Okay, so first let's just kind of level set what is a GLP-1 agonist. So in our small intestines, we have some receptors. We actually have them all over our body, including our heart, our brain, GLP-1 receptors. And the job of the GLP-1 receptor is when you eat, your GLP-1, your natural GLP-1 hormone binds to the GLP-1 receptor, and then that sets off a cascade of signals, which is super complicated. It goes to your brain and your hypothalamus, which is deep in your brain, and tells you, hey, you're full. You don't have to eat anymore. That's the natural path of the GLP-1. Well, they found that there was a lizard actually that in a remote island, they found that this one lizard, the saliva carried a ton of GLP-1 in it. And this lizard could go without eating for a really long time. And I don't know all the stats on it, but they developed this molecule and they figured out how to create it into an injection. And then they figured out, well, hey, if we give extra GLP-1, it binds to the receptor, which then helps the patient to feel full much quicker. So it sort of enhances the natural GLP-1 process. So that's what GLP-1s are. And by the way, there's a lot of other receptors that do similar things. For example, there's a GIP that now there's a new drug. You probably heard Mounjaro or Zepbound, tirzepatide, not yet approved in adolescents, but it's now hitting 2 receptors. So I'm saying this to kind of give you a preview of the future. There's even drugs coming out that are going to hit 3 receptors, and I think even more than that. So the science is just blossoming on this. But anyhow, so GLP-1 receptor agonist, which is what these drugs are that we're talking about, they bind the GLP-1 receptor. They've been around for a long time. So the first one that was on the market was liraglutide, or some people call it Lira. And basically, this is a daily injectable. And what it does is it binds to the GLP-1 receptor. And through that pathway we just talked about, it also helps improve insulin resistance. And we don't have to go into the details. So it was initially made as a diabetes drug, or Victoza. And then they studied that. FDA approved Victoza down to age 10. So this is even prior to all of the obesity drugs kind of being marketed, right? So we've had Victoza around. The endocrinologists have been using it safely down to age 10 for several years now. And then they decided to market it for obesity because they noticed that these patients with diabetes were full, they weren't eating that much, and they were losing weight. And so they marketed Saxenda, which is liraglutide brand for weight loss or obesity. And then that's been approved for a couple years now. So that was our first injectable we had for adolescents. So who should prescribe this? Well, any pediatrician or family practice doctor who has a patient, and I would say let's just talk about FDA indications. If you have a patient 12 and up who is interested in medication, that should be one that you consider offering. So Saxenda is the brand, and it's liraglutide, and it's going to go and bind that patient's natural GLP-1 receptors, help them to feel full much quicker, along with help their insulin resistance and all the pathways. So that's the first one, liraglutide. I call that the original. And then there was semaglutide that came around and really shook everybody up, because if you look at the adolescent studies for liraglutide, the average weight loss was about 6%. Still pretty good, right? Remember I told you the FDA wants 5%. So liraglutide performed pretty well. That Qsymia I told you about performed about 10% weight loss in the adolescent trials. And then came semaglutide, and it performed at 15% weight loss average. And this is over a year's time in adolescent studies. And again, remember, anytime you have something coming out on the market, it's already been in trials for almost 10 years, probably 5 to 10 years. And so these drugs, I think the number one thing I want people to understand is they're not just like new, like we just whipped it up like they did with the COVID vaccine. Like these are drugs that have been studied, have been in randomized controlled trials. The government, NIH, has been supporting these studies. This has been in the pipeline for a long time. So that's semaglutide. It's our latest and greatest. It's my favorite one to prescribe. Why? Because it's the most weight loss in the study. So 15% weight loss, and we go from a daily injectable to a weekly injectable. So now patients can just give the shot once a week. And then they still, of course, all of this is at the same time as working on nutrition and lifestyle goals. And so I want to make sure that we talk about that as well, because I think that was a lot of the backlash is about the guidelines. People said, well, you can't just give kids and adolescents and teenagers medicine and they're just going to not do the work. And it's a quick fix and you're not really fixing the problem. And that's exactly right. Like you can't just give someone a prescription and say, see you later. And that would not be recommended for any medication, right? In pediatrics. So this is always in light of, look, here's a medication that will help your metabolism. It'll help regulate your hunger and your fullness, your satiety. It'll work on the biology while you work on the other stuff with us as a team, and I think it's a give and take. We're going to help you medically, but here's some, let's talk about what you and your family feel like they can change in your environment.
I appreciate you bringing that up. I mean, the medications are extremely helpful. Some people, though, are concerned about maybe the risks or side effects. I've seen reports and concerns, and I don't know to what extent it's been borne out in the evidence, but you definitely see concerns about effects on thyroid hormones or thyroid cancer risk, and also enjoyment, because sometimes they seem to have what's called a flat affect, where they're just don't seem to enjoy their life. They're not motivated to eat. I've seen a lot of these concerns coming up. Honestly, I'm going to say mostly in the social media, which is, not always a reliable source. We will recognize that. But can you speak to that a little bit? Because I know listeners are probably seeing that as well. And they're going to wonder, well, what is the downside? What are the risks or potential side effects of these newer medications?
Mm-hmm. Yeah. And I think anytime you're talking about medication, it's a risk benefit, decision. And it's a decision that's between you and your doctor, right? So nothing that we say today is recommending your child should be on a GLP-1. But in the studies, they did have some mice. These are the mice original studies that had increased medullary thyroid cancer. However, in none of the human studies have they shown this linkage. But it is listed on the label that we should ask about family history of medullary thyroid cancer or something called MEN type 2, which is an endocrine cancer syndrome that families can have. So that's one thing. But as far as affecting the thyroid function, that's not typically something we worry about. That cancer risk is really only if your family has that risk in your family. The second thing you mentioned was about what you would say is like, you take away my joy of eating, right? If somebody took away my joy of eating, I think I would be a little bit depressed too. And that's a valid concern. I think my goal is always to not completely take away the joy of eating. My goal is to calm down the hyperphagia. So if I have a child who tells me, you know what, my appetite's not that high, I'm not that hungry, you know what, maybe GLP-1s and medication is not what's needed, right? So these are really effective when patients have hyperphagia. They're always hungry. Either their stomach's always growling, or they always feel like they have to eat a large portion to feel any fullness, or they feel like they're always thinking about food or craving food. That's the job of the medication. It helps to lower those cravings and improve the satiety. But if a patient doesn't have that, I wouldn't prescribe it. In the same sense, if a patient gets on the medication and they come back and say, basically, they don't have any hunger, like they're just forcing themselves to eat, it's probably too high of a dose, in my opinion. So I want patients to feel hungry when it's time for a meal. I mean, that's just normal physiology. So we're just trying to restore the normal physiology. We're not trying to completely block out the hunger. And I think that's a good doctor is going to be asking those questions, and is going to be lowering the dose if they have that sort of lack of pleasure of eating.
Thank you for clarifying that. I think it's an important point. Now, from my point of view as a physician and a potential prescriber, the other hot topic is, how do you get this stuff paid for? I mean, I can prescribe it, but if insurance isn't going to cover it and my staff is having to spend hours and hours chasing approval, how effective is that? What should providers be aware of, and what are you seeing in terms of insurance approval?
Well, it's completely dependent on the state, and there are several states that have coverage, like for example on Medicaid, and there are definitely lots and lots of private plans that are covering this. But I would say yes, like you're saying, the majority of plans, majority are not covering it. However, this is my argument: is that if we don't prescribe it and we don't continue to send the scripts and do the appeals and the prior auths, they're never going to cover it. And so I think it could be something as simple as if you're a pediatrician or family practice and you want to start prescribing, maybe pick one out of the 3 drugs to get comfortable with, and maybe only prescribe it to those families who have coverage, which might mean you put the onus on the family and you say to the family, hey, if you call your insurance plan and they cover this, I'm happy to write it. But we just don't have the capacity right now to go through all the appeals. Now that's one thing you could do. On the flip side, you could find a really strong champion in your office. Like we have really good MA, and we actually have a pharmacist who helps us, who made a nice process. And we do the PA, we appeal, and we second appeal every single medication. And we have gotten recently 12 patients covered on Louisiana Medicaid on GLP-1s. And that's huge because it's not on the PDL for Louisiana Medicaid.
That's
and
amazing.
so like my husband says, if you don't ask, you will not receive.
And it does require a lot of effort from, I think, both the physician and the patient. But again, as with many things in my life, going back to our experience with the complex epilepsy syndrome, some of the medications that we were offered over the years, because, we tried and failed all of the usual ones, were not standard medications and you did have to go out of your way as a parent to aggressively pursue coverage under what's called a compassionate use clause or something like that through your insurance. And families were able to get things done that weren't even approved here in the United States. There was one, and again, it is now because my daughter's 21, so this is going back, but one that we used to order, and because we could afford it, we paid for it out of pocket, but it was allowed to be imported to the United States from Europe under a compassionate use basis. And she didn't have Medicaid, but the families that I know that did have Medicaid were able to talk Medicaid into getting it covered, even though it wasn't even something approved here in the United States. So it can be done if you are motivated enough and aggressive enough with your insurance. But yeah, it takes effort. And I know if my nurses are listening, they are rolling their eyes because they spend so much time, just those ADHD medications you were mentioning. Oh, we spend so much time trying to get approval. But yeah, you're right. It's a good point. If we're doing it for other medications, we can do it for this as well.
But it will get easier and easier, I would say. And I think also just going back to, there are some cheaper options. Like I mentioned, phentermine's probably about $30 to $40 a month for 17 and up. If you're going to prescribe phentermine, it's alone at 17 and up. Qsymia, which remember is the topiramate phentermine together, that's the oral medication, that's $100 a month cash pay. Sometimes a little cheaper if you have insurance coverage. And then you've got the GLP-1s, which cash pay are about $1,000 and up. However, if you are associated with a clinic, that's an FQHC, a rural health clinic, or a hospital-based clinic, you may have access to special pricing. It's called 340B pricing. So for example, we get our weekly semaglutide as low as about $350 a month. Still super expensive, right? But there are some kind of workarounds that you can look into.
We're not, unfortunately, any of those special clinics. We're just a privately owned pediatric group, but I'm still going to look into it. So thank you for that tip. Now, you mentioned the importance of the lifestyle changes, the healthy lifestyle habits, and that is definitely a part of the AAP clinical practice guideline. It states, medication and or surgery in addition to the intensive health, behavior, and lifestyle treatment. And personally, that's really where I'm focusing my efforts, right? I am pursuing board certification in lifestyle medicine rather than obesity medicine, but they align quite a bit. There's a lot of overlap in terms of how you approach that. So it is important to point out that that is always the foundation, the healthy habits and cutting out the ultra processed foods. It's just that the medications are going to make that easier to follow and implement. Am I correct in understanding that?
Exactly. Because if you understand how the medicines work, which we kind of just briefly went over, and you take away that biological drive to eat, whether that's reducing appetite or improving fullness, it just makes it easier to not eat the chips or crave the sugar. And so when you fix the physiological signals and the physiological metabolism of how your body's going to handle those chips, so you fix that, then the good old calories in, calories out, when your car is running better, it's gonna work, right? The calories in, calories out equation does work when your car is running well. And so the medicine sort of restores the car and makes the car work so that you can do the lifestyle change.
So doctors like you are making it easier for doctors like me to have an effect on their patients, to help their patients. So if we can work as a team, that's always the best teamwork. You're with your state chapter on obesity and the founding board member of the Louisiana Obesity Society, as I said in your introduction. Tell me a little bit more about what kind of advocacy we need to be doing at the government level, the policymaker level. What kind of policy changes do we need, not just for medications, but to help improve access to the lifestyle programs and all of these services? And I ask, a little bit out of a selfish kind of level, because here in Texas, we're definitely one of those states that does not do a good job of funding this. And it's very difficult. In fact, one of the main driving forces, the reason behind my interest in all of this was I saw the growing need in our patient population, and I wanted to refer my patients to an obesity clinic or someplace where they could get, see a dietitian, work with a multidisciplinary team that would be effective in helping them with their habit change. And I realized there weren't any. And we are between two major cities. We're between Austin and San Antonio, and there were zero programs for why am I not referring my patient to these programs? Because there's no place to refer them. And I think a lot of that has to do with the policy level and reimbursement and what sort of changes need to take place at that level to help make this a more successful program.
Right. And I think that is probably the biggest advocacy opportunity I think that any pediatrician has, whether advocacy is you doing that PA and that appeal. So don't get me wrong. You don't have to go up and march at the state legislator. Like, that's advocacy, you trying to advocate for your patient medical necessity of a medication. But as far as these intensive lifestyle programs, I'll be honest, part of the problem is it's twofold. It's the funding for the program to run the program and to continue and to have the staff to continue the program, but the reimbursement is it's iffy. So in other words, you might spend all this money to set up an IHBLT program, and you might get half of the payers to reimburse you with the codes you use. And there are lifestyle and counseling codes that physicians can use. There's some that social workers, dietitians can use. You can have a social worker or a dietitian in your community offer this. But again, there's not consistent reimbursement. And so I think that means that most programs that survive on grant money or research money. And we haven't gotten to a point in our country where even though we know it works, we know intensive lifestyle and behavior programs work 26 hours or more in a year's time, to be exact. The problem is the reimbursement for that. So what could you do? You could write a letter to your plan that, hey, I want to be part of this program, or if I start seeing my doctor every 2 to 4 weeks, will you make sure you cover it? That's one thing. And then another thing is that the American Academy of Pediatrics and the section on obesity, which is the national section, they are working closely with the ICD-10 codes, and there's some new ICD-10 codes for obesity. And not just that, there's some new CPT codes, which are your professional codes that they're working on to cover intensive behavior and lifestyle treatment. So there's a lot of people working on this. And I would say if you want to be part of that, you would reach out to the section on obesity and they could link you into the work being done on that level. But you mentioned policy. So policy, I think, is what I've learned is policy takes a lot longer. For example, there's a policy that's been proposed, a bill that's been proposed in the U.S. Legislature for the past couple of years called TROA. Are you familiar with that?
I've heard of it, but tell me more about it.
It's the Treat and Reduce Obesity Act, and it's a bipartisan bill, and it would basically require Medicare or CMS to cover both obesity medical visits, but also obesity medication and bariatric surgery. So it would require comprehensive obesity care for patients on Medicare. And why that matters to us as pediatricians is because everything that Medicare covers usually trickles down and then the state Medicaids cover. And then usually the private payers follow. So CMS really leads the country in what's covered, right? So this bill's been around for a long time, and they just keep fighting over it basically. But if you wanted to get involved in anything, I would say get involved in TROA. You can go to the Obesity Action Coalition and find out how to get involved in their advocacy work. And then, of course, you can always talk to your state legislator. Like, for example, my state legislator is actually one of the authors, I come to find out. And so we've tried to connect with Bill Cassidy, who's one of the authors, to see, hey, if you need a pediatrician to stand up and fight for this bill, just let me know.
Great. I will look into it here in Texas and see who, if anyone, is supporting that. And if not, maybe send them a letter recommending that they support it. Dr. Queen, I really appreciate your time today. You've distilled this information down into something that's a lot easier to understand, and I think answers a lot of people's questions about it. I think it also highlights the challenges that we have as healthcare providers. We want to do the right thing and we want to help our patients, but it's a complex issue. There's complex causes. We didn't even talk about the causes. The causes of obesity are super complex. The treatment, therefore, also is complex. It's not going to be one individual thing. And we all have our roles to play, and there are a lot of components that are going to go into it. And I really appreciate what a good job you did of talking about the non-surgical approaches to treating pediatric obesity and giving us some insight into what goes into that. So excellent job. Thank you so much for your time. Did you have any follow-up comments that you wanted to add before we wrap up?
I think I just want to say to those families that might be listening who have a child or an adolescent with obesity, again, I think the takeaway is that obesity is a medical condition. And because it's a medical condition, at some point, it may be, I don't want to say futile, but it may be extremely hard for you or your child to fix it on your own. So don't be afraid to go reach out to your primary care doctor to talk to about your concerns, to ask about the options like we talked about today. And also the number one takeaway for me is it's not your fault. It's not the parent's fault. It's not the child's fault. It's a combination of a lot of complex causes that leads to obesity. And in many kids, it's never the same thing. So I just want to tell everybody, if this is something that is hitting home, just know that there's a lot of families out there struggling with this. And it's okay to ask your primary care provider for help with it.
And I would add, as a primary care provider, if your doctor is uncomfortable or just doesn't understand all the different ways that it can be treated, because let's face it, we are not educated on this in medical school. Maybe it's changing. I hope it's changing, but we don't get a lot of education in medical school or training. So first of all, don't blame your doctor if they don't know. Look for an obesity medicine specialist in your area because it's a growing specialty, even in the pediatric field. There are great doctors like Dr. Queen out there. If you're fortunate enough to live in Louisiana, go see her. But if not, look and find the resources in your community if your own primary care provider is not able to help you. Don't give up.
Yes, and you can go to the American Board of Obesity Medicine website and you can search for a provider in your state to see who's credentialed and who's comfortable with prescribing.
Great. So there are resources. Thanks again for your time. I know you're busy and enjoy all that great food in Louisiana. And if I'm ever over that way.
I just ate my red beans and rice every Monday. I ate my leftovers from yesterday. Every Monday have red beans and rice down here in Louisiana. So anybody who comes out and wants to reach me, I can share my email in the show notes. I'm happy to share.
Perfect. I'll put all your contact information there. Thanks again. Have a great day.
Awesome. Thank you, Dr. Black.
Wow, what a great conversation with Dr. Queen that was. I hope you learned as much as I did about this subject. Now, I understand that this is a controversial topic and people have really mixed feelings about whether or not weight loss medication should be prescribed to children. And I hope you came away with a little better understanding of the circumstances under which a doctor might consider prescribing them and why it's important. We are talking about improving health outcomes. And if you've listened to any of my previous episodes, you know how committed I am to supporting patients in developing healthy lifestyle habits, including eating an excellent, nutritious diet rich in those whole plant foods that we know our body needs, and in supporting other healthy habits like exercise and sleep. But let's face it, we don't live in a perfect world. The obstacles to being able to do that are sometimes insurmountable. There are so many causes. Just the culture that we live in that is flooded with fast food, junk food, the sometimes unsafe neighborhoods where children may not have the opportunity to get out and be active the way their parents would love for them to be able to do. Let's make sure that we are approaching this topic with a lot of sensitivity and compassion for the many barriers to health that exist. And I agree with Dr. Queen and the American Academy of Pediatrics in that all the options available should be presented to a family and the patient so that they can make the best decision for themselves. What's right for each individual is different, and people can only make the best decision when they're presented with all of the information and all of the options. I hope you enjoyed this podcast. I will put the links to the American Academy of Pediatrics clinical practice guideline on the treatment of pediatric obesity in the show notes, along with the link to the American Board of Obesity Medicine, so that if any of my listeners want to understand it better or are looking for a board-certified pediatric obesity medicine doctor in their area, they can find that more easily. You can reach me with any questions about this important conversation through the Eat Greens with Dr. Black website on the contact page. I welcome genuine questions and encourage thoughtful, respectful dialogue on this important topic. Thanks again for listening, and don't forget to eat your greens.
Please be aware that this podcast provides general health information about nutrition and feeding of infants and children and is meant for educational purposes only. It's not intended to replace the important relationship between a parent, child, and pediatrician. If you have concerns about your child's nutrition, health, or growth, please consult your doctor.